Hello, this is the DAROGA video number 22, and today we are dealing with OSCE, Objective Structured Clinical Exams, Pearls of Wisdom. This is a topic specific for Year 5 medical students. The overview of today's lecture. We commence with an introduction. Then we focus on what possible skills and competencies could be tested in an OSCE, the structure of the OSCE as we do it here in South Australia. Firstly, what are do's and don'ts in the hallway when you're reading the task at hand, and then what are steps to take when you're inside the room. This part is we pay attention to the theory, and we illustrate in an example OSCE how you could apply the above rules. We finish with a conclusion and an important question regarding our Master-in-Chief. What could be possibly tested? Clinical skills, performance and competence. Firstly, taking a focused history. There is usually no time for a full and detailed history. Usually we use a simulated patient or a volunteer, hardly ever a real patient. Part 2 is clinical examination. Again, in principle, we don't make use of a real patient for obvious reasons. Usually you can ask examination findings from your examiner. It could be also that you have to deal with a model, in vitro model of an abdomen, a pelvis, or even a picture. Part 3, you are encouraged to request certain investigations, bloods, urine, ultrasound scan, x-rays maybe, CTGs, etc. And usually that goes via the examiner. Here he is. Let's go back to taking history, point 1. Usually it's requested to focus on the presenting complaint. Include associated symptoms and risk factors. Usually 4 to 5 questions will provide the relevant cues. Here applies the rule better is the enemy of good. So you could ask 7, 8, 9 questions. But in principle, you will lose precious time. What I see as an examiner, that students like to go back to ask to full questions, to full details, questions about the history, and that's where you feel comfortable with, but that appears to be a trap in OSCE exams. Part 2, clinical examination. Usually, it's important here that when you examine the patient or you ask from the examiner examination findings, that you do it in a systematic way. And by the way, now it's fine to use medical jargon because the examiner understands that quite well. I would recommend you to use this sequence always. Start from general. You could ask a question such as, what are her vitals, please? If the patient, by the way, is not stable, then you don't continue with asking questions, but you would do airway breathing and circulation, the ABC resuscitation, and you call for help. Abdominal examination, do it systematically. Are bowel sounds present? Can I feel a mass? Are there signs of peritonism, ascites? In obstetrical case, you would like to know the fundal height, the fetal line, the presentation position, the fetal heart rate, etc. And the pelvic examination, usually inspection, speculum examination, and bimanual digital examination unless contraindicated. When you ask for examination details, provide the examiner with specific information. What in particular are your eyes looking for, your ears listening for, your fingers feeling for, and sometimes even your nose smelling for. Be very specific. For instance, early pregnancy with bleeding, you would like to know when you do a speculum examination whether the cervical os is open or not. Can you see blood passing or products of conception. Obstetrical case, for instance in a ruptured membrane scenario, you would like to do a sterile speculum examination and ask for, can I see fluid? Is there pooling? Other questions you will ask in case of an antepartum hemorrhage, preeclampsia, intrauterine growth restriction, transverse lie, and so on. If you're dealing with a gynecological case, what you ask for depends on, for instance, if it's a case of sexually transmitted disease, you would like to find out if there is abnormal discharge from the urethra or the cervix. Sterilization request, completely different questions you would ask, is routine. Uterovaginal prolapse, you would like to verify what is the nature and the severity of the prolapse. So that's what I mean by what you ask for when you examine the patient via the examiner. You ask specific information. Here, a pelvic model could be used to test your skills, how you would perform a speculum examination, or how you would take a pap smear, a thin prep, or a vaginal swab. Obstetrical examination skills could be, are you able to demonstrate the Leopold maneuvers, or how to palpate the fundal height, or how to measure the fundal height, etc. If you continue with skills being tested, quite often you are required to interpret the results of investigation you have requested before. Explain to the patient or the examiner, and it depends again, patient, you don't use jargon. When you speak to the examiner, that's fine. Discuss then, task number 5, the most likely diagnosis or the differential diagnosis. Usually you address that, you speak to the patient. The last thing, this number 6, is discuss your management plan. Again, you usually will focus your attention to the patient. And of course, task number 7, it's always important, the communication skills. Use plain language, avoid jargon. We will check your listening skills, whether you show genuine empathy, and whether you show the ability to build rapport with the patient, the volunteer. By the way, in every station your communication skills will be part of the explicit and implicit assessment. By the way, if the patient and the examiner like you because of your appearance, because of your appropriate bedside manners, they will subconsciously support you and mark you even more favorably compared to a student who comes across as very clinical. Important, for instance, if you would find out that when you take the obstetrical history, the lady tells you that she had fetal demise at 26 weeks, that you take that on board and you show, well, that must have been difficult for you. That's completely different when she would tell you she had an appendix removed in the past. Theoretical knowledge. In principle, theoretical knowledge is tested in written exams, such as the short answer questions, MCQs or SATs. Yet, without basic knowledge, you will struggle in an OSCE case. Okay, in the hallway. Crucial that you spend your time here wisely. Usually your preparation times is 1.5 minutes. I would recommend you to read what is given at least twice and take deliberately on board what are the key points of the clinical scenario and what are the expected tasks from you in this particular station. When you read, you probably can come up already with a most likely diagnosis, and usually that's right, because OSCEs are not planned to fool you, to lead you up the garden path. So what am I expected to do? In principle, we check 1, 2 or 3 of the possible 7 skills we discussed before. So stick to these tasks. If you digress, you waste time and you miss valuable points later on. Inside the room, I would recommend you to start with, "Hello, Mrs. Such and Such, my name is, I'm a year 5 medical student. If I stand it correctly And here I would encourage you to make a brief summary what you have read in the hallway. The patient, by the way, could alter your summary free of penalty. She could say, no, I'm not 27, I'm 31 years old. This is not my second pregnancy, etc. If not, if the patient doesn't correct you, you're probably on the right track, and that will give you immediately a confidence boost. If you lost it completely, what could happen, reread the information, because inside the room we have a laminated sheet with the same information as in the hallway. So it's fine to read for another 20-30 seconds. Do not check the date of birth of the patient or her address, which is custom in the first couple of years, and do not ask questions about what is given. If it's stated that she's 27 years old and she presents with postmenopausal bleeding, I would not tell her, how can I help? Which you would do in general in your practice, in your daily practice, because you save precious time. Time constraints is part of the deal, whether you like it or not. My recommendation as well, to always try to reduce the complexity of a particular case by identifying the key issues. What appears to be very complicated becomes then 3 issues you want to identify and manage. Also great when you have identified these issues that you use that to inform the patient about your management plan or investigations. As we discussed already, when you examine the patient, only ask for the things which are relevant to the case. So don't do the routine stuff. Be specific. What investigations are appropriate? Or again, be specific. Limit yourself. A shotgun approach would mean you lose precious points. Moreover, you won't get all the results you might have asked for. What is the diagnosis or the diagnoses? What would be the management thereof? Explain each issue systematically to the patient. Yeah, there's a whole book written about performing under pressure, and that's what it is. Okay, that's enough theory. Let's move on now to an example, as we have actually used at the University of Adelaide in South Australia a few years ago. Here you are in the hallway. You're a little bit nervous, that's fine, and here is the case. A 27-year-old woman presents to a rural hospital emergency department with intermittent abdominal pains. She is pregnant and her gestational age is 31 plus 2 days, 31 weeks and 2 days. So, how does that sound? What is your initial impression? Yes, probably your initial impression is right. The case continues. The woman normally lives in the metropolitan region, 4 hours away by car. She's traveling with her husband and their 3-year-old son and has forgotten to bring her pregnancy record. However, she believes that her pregnancy has been uncomplicated so far and that all screening results have been normal. Her dates were confirmed by an ultrasound scan at 12 weeks. The written information continues. We are not testing competency calculating or confirming the due dates. Task. Please take a focused history from the woman, 4 minutes, then advise her of your provisional diagnosis, propose investigations and plan of management. Wow, yeah, I understand that you feel somewhat like this poor chap. However, keep calm and suppress your feeling, are you kidding me? Yes, this is a quite long case. Quite long, and you run the risk that you don't see the forest for the trees. Yeah, what some of us want to test as well, that the students, the future doctors, are able to take complex information on board. Something like this. So stay calm, identify the key issues and work through them systematically. Okay, let's go back. Where am I? Important to take on board that you're in a rural emergency department. You're not in suburbia in the city. This means in Australia, far away from a hospital with neonatal care facilities, so you are more at the level of a local GP or GP obstetrician. You are in an emergency department, so this is not a routine antenatal visit. This means most likely that you need to start initial treatment over there locally and then arrange transfer to a woman to the city. In South Australia that means Adelaide. So keep this in the back of your mind. Most certainly that will give you an extra point. The example continues. She is pregnant, that's a given, no doubt about it. The same applies to the gestational age of 31 plus 2. It's a given, no doubt, trust us. What was given as well that you should not take here a detailed history about her last menstrual period, her menarche, her length of the menstrual cycle, when the positive pregnancy test appeared, her early ultrasound scan, etc. All these questions are a waste of precious time in this scenario. However, that's different from an early pregnancy scenario where we want you to find out, we want to find out whether you're able to determine the expected day delivery, and all above questions are paramount. Let's continue to analyze. Intermittent abdominal pains. Sounds like labor. Could be labor. So you need to ask a few more questions about the presenting symptom. Maybe 5, but not 10. Focus history, that's what we mean. The example continues and let's analyze. The woman normally lives in a metropolitan region, 4 hours away. She's traveling with a 3-year-old son. That means she has already 1 child, so we need to ask more questions about that. Rural was already stated again, so that must be important. Para 1, no further information, so we need to ask questions about her first pregnancy. Current pregnancy was uneventful so far, so you don't have to ask, there were no complications. Dates are firm, mentioned for the 3rd time. Well, maybe 1 time's too many. This is most definitely a case where there is information overload. This will, without doubt, add to your feeling being under the pump. So focus is the key point. What are the issues? Okay, inside the room, you will see the patient, the volunteer, and the examiner. Yeah, here he is again. What is your first impression? How do you look like? Professional? Meet and greet with a friendly smile, and pass the stickers with your name on to the examiner. Start the introduction where I recommend you to summarize the hallway information. This is already discussed, so this slide is a duplication. Now ensure that you pay attention to all 4 tasks. Take a focus history, 4 minutes, and then advise her about your provisional diagnosis, proposed investigations and management plan in just 1 minute. Don't get bogged down in just 1 or 2 tasks. For instance, taking a full history. You will miss important ticks from your examiner. If it looks like a duck, it sounds like a duck, and walks like a duck, most likely is another horse. So in this particular case, it sounds very much like labor, preterm labor in a country setting. That's the focus point. Ask a few questions about the nature of the pain. I would suggest you to ask an open question. What can you tell me about the pain? Because you know how labor usually commences. It's either with uterine contractions and it's intermittent, non-continuous place, or rupture of the membranes. The water has broken. So it's probably appropriate to ask her a few questions about possible fluid loss from her vagina. What are the characteristics of the pain? So I suggest to ask an open question because they are quite often very time efficient in an OSCE setting. The patient or volunteer will tell you all the details in response to your question. Of course, it's good to take general well-being on board and you ask a question about PV loss. Have you noticed any loss, any fluid loss from your vagina? If not, you move on. If yes, you ask an open question. Can you tell me more, etc. Fetal movements, important in an OSCE, an obstetrical OSCE. Always you check the fetal well-being by asking this question. What can you tell me about your first pregnancy and delivery? Were there any complications are the two questions where she will give you all the relevant information. Another question you could ask, I think it's a very smart question to ask, is there anything else you would like to tell me? It's a great question, and if the patient likes you because of your friendly smile, she will most definitely help you. Examination, in this case not required, so we have to skip that. It's very counterintuitive for you as a thorough methodical doctor to be, but it's not requested in this scenario. Don't wait precious time, there is no points to be gained here. Now 3 more tasks in just 1 minute. Provisional diagnosis, proposed investigations and management plan. Hence, you only have just enough time to list. It's impossible in daily practice where you want to explain everything very thoroughly, make sure that your message came across, you build a rapport, etc. Yes, this is a requirement in most OSCEs, so adapt like this little fellow here. Provisional diagnosis, roughly 20 seconds. Focus your attention to your patient, only use layman's or laywomen's terms, I should say, and continue to show empathy. For instance, I'm glad you came to see us. Based on what you told me, I see 3 important issues. I'm concerned about 1, you are only 31 plus 2 weeks pregnant. 2, it appears that labor has commenced. And 3, your water has broken. That's enough to get full marks about the provisional diagnosis. Then you could add 1 or 2 more sentences. It's important to find out how far your cervix, the neck of your womb, is dilated. Hence, I would like to examine you. You have tried to reassure her and share with her that you're somewhat concerned, but by no means panicky. Propose investigations, 20 seconds. Tell her succinctly what and why, that you want to check the baby's heart rate to confirm that the baby is okay. We call that a CTG. Take bloods and urine samples to find out if there is an infection. We check full blood count, CRP, group and hold. Take some fluid from your vagina to confirm that the water has broken. 4, I take a swab of your vagina to tell us what antibiotic we might want to use in the future. And if available, I like to do an ultrasound scan to check the fetal large presentation position and size and well-being. Well, hard work within 20 seconds. Then the management plan. I would suggest something like you might be born in a few weeks, a few days time now, and that's I would like to suggest that we give you antibiotics via a drip to reduce the risk for an infection of your baby. 2, give you another drug via an injection in your muscle. We call them steroids to stimulate ripening of the baby's lungs, etc. And as your baby might be born too early, we would like to arrange transport to the nearest hospital in the city, and I'm going to arrange an ambulance or a plane, a Royal Flying Doctors, depending where you are. If there is time left, you could ask her, what question do you have? Or, what did I not explain well enough? By the way, if you have completed all 4 tasks, you probably have done very well, and it's perfectly alright to remain silent and unwind for a few seconds. What is the examiner's perspective? Yeah, here he is again. A competent candidate will 1. Evaluate maternal well-being, 2. Fetal well-being, arrange appropriate emergency care, and as far as the well-being, detects, identifies that we're dealing with preterm labor and preterm rupture of membranes, will organize basic investigations like a foot blood count, CRP, an amniotic fluid test from a speculum examination, for instance, Ferning, to confirm PROM, evaluate fetal well-being by asking the question about fetal movement, thus auscultate for the fetal heart when examining the lady, and would request a CTG. Then, number 3, the appropriate emergency care, suggest antibiotics and steroids, and might offer tocolysis. That's an option because that's not absolutely required in this scenario, and would transfer to a metropolitan hospital with appropriate neonatal intensive care facilities. So that's the examiner's perspective. This is what the examiner would like to find out. Conclusion: in the hallway you lay the foundation for a successful OSCE by reading carefully and find out what tasks are requested from you. In the hallway you probably can come up with a most likely diagnosis already. So you deliberately, consciously take on board the key information provided and the task requested. In the room, complete just the task requested. No more, no less. Ask questions and explain in a succinct and friendly manner. Your professionalism and communication skills will always be part of the assessment if there is a patient in the room. Yeah, OSCE prepares you for working under pressure, which is sometimes part of your future profession. This concludes OSCE Pearls of Wisdom, and as always there is now a question about what is the difference between Zen Master in Chief Jimmy and a medical student at an OSCE. The student will, I trust, be able to see the forest for the trees. Jimmy keeps on sniffing at each and every tree. No clue he is in a forest. Good luck.